Today's episode about eyeballs is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. This is AI-powered technology that helps physicians be more efficient and reduce clinical documentation burden that causes people to feel a bit overwhelmed and burnt out. To learn more about how DAX Copilot can help reduce burnout and restore the joy of practicing medicine, stick around after the episode or visit nuance.com/discover-DAX. That's nuance.com/discover-DAX.
Knock, knock, hi.
Knock, knock. Hi. Hello, everybody. Welcome to Knock, Knock, I, with me, your host, Dr. Glockenflecken, your one-stop shop for all things eyeballs. This is where you want to go. You don't buy eyeballs from me, but you do learn about them. And I really enjoy, I've grown to appreciate the time I get to spend in the evenings recording these episodes about all these different topics, some of them about ophthalmology that I haven't really thought about in a while, like retinopathy or prematurity, or eye worms, and some very common topics like glaucoma or various trauma-related things. We kind of go all over the place, and so I encourage you, if you're wondering, when is he going to cover this topic? When is he going to cover color blindness or whatever it is you might be interested with your vision? Go back and look at some of the prior episodes. We post them every Thursday, and see what I've done already. And so I've done a lot. We're going to keep going with it. We're probably like, God, I don't know, 25 episodes into this. And so every week we got a different eyeball topic. This week it's thyroid. We're talking about thyroid eye disease. I've gotten a number of requests about this. Before we get to our topic, though, I want to talk about a few things. I have been informed, and this is not the first time I've heard this, that I talk slow. I am a slow talker. I don't deny this. I did grow up in Texas. If you grew up, I know I don't sound like it. Somehow my mom has a tremendous Texas drawl. My dad does not. I don't know how I escaped it. Well, I haven't lived in Texas since 2008. So you do kind of lose those things. There are home videos of me as a kid with a Texas drawl, but I have lost it now. So people are surprised. You don't sound like you're from Texas. But I do. There are certain characteristics that I've kept, and one of those things is that I talk slow. This is a real thing for people who grew up in the South. I don't know, everybody just talks a little slower, and I really felt this when I moved from after college. Kristen and I moved from Texas to Dartmouth, to New England, which is the opposite end of the spectrum in terms of the speed at which one talks. And I noticed it. As soon as we got there, I was interacting with all these attending physicians and people, and my classmates who are from the North or other parts of the country. And I was like, wow, they really do talk fast here. And it sounded like my mouth was full of like syrup, marbles. Like I couldn't get words out fast enough for these people. It was a noticeable difference. And so it doesn't surprise me to hear that. It was a good friend of mine who informed me once again, you talk kind of slow. And Kristen, in our Knock Knock Hi episodes, she talks kind of fast. So it does make for tricky. I wish you could do like selective speed adjustments based on who's talking. That's an area, that is an innovation with listening to podcasts are so popular now. I feel like we should have that, right? You should be able to say, okay, when Dr. Glockenflecken is talking, I want it as 2x speed. And when Lady Glockenflecken's talking, just normal, because she talks at a reasonable pace, that a normal person would enjoy listening to. And so I guess I'll just say, thank goodness you can speed me up. I hope you're doing that. I hope you're breezing through these eyeball episodes at whatever you like to do. 1.25, 1.5, 1 3/4. I don't know. I don't know what it takes. But I will not apologize for the speed at which I talk. It is just who I am, and it cannot change. I can't do it. I can't speed myself up at this point in my life. I'm almost 40. Come on, I am what I am. All right. So I apologize to all of you who are like, you shouldn't be mad at me because you can speed it up. That's the beauty of technology now, right? You can put me at whatever speed you want. Anyway, I'm just going to keep talking slow. Anyway. All right. I hope you've had a good day. I enjoy, this is honestly a way to help me decompress a little bit from long days as an ophthalmologist. And yes, we do have long days occasionally. I did today do my physical training. So I am a bit tired. I'm a bit sore. My trainer was on my ass today. He really did a number on me. I was squatting the hell out of everything in that gym today. And I am not like super strong. Like, this is why I have to have a trainer, because I do not have the self-discipline to, on my own, go to the gym to exercise, to lift weights. And you can tell because ophthalmologists are physically the weakest specialty in medicine. And I look it. I'm very lanky. I'm tall. I'm skinny. I put on a little weight as I've gotten through my 30s, but still, so I'm trying to fix that. I'm trying to like get into a habit. But I needed somebody at my local gym. I needed to basically pay someone to just make me so tired and it just put me through the ringer. And I need to have like skin in the game to force me to do this. So, and he really I am going to be hurting tomorrow. So anyway, that's the state I'm in right now. I'm very tired. I thought about recording a skit tonight, but holding the phone up in front of me to record myself felt like too much for my muscles. So instead, I was like, I'll just sit at the microphone. I don't have to move too much, and we'll just talk about eyeballs. All right. The other thing I want to discuss before we get to our topic is the parasite episode. So I went through the comments. Let me just talk for just a second about like internet comments. They can be overwhelming. You know, I actively post on all the platforms: YouTube, TikTok, Instagram, Facebook, X, Twitter. I would say that the comments, I cannot get to all the comments. I don't. In fact, some platforms, I never read the comments. I just don't have time. I can't do it all. So I'll rarely read comments on Instagram and Facebook. I would say I probably read the most comments on YouTube and then TikTok as well. And part of that's because they're so funny. You guys are hilarious. Like you routinely make me crack up on the comments on my skits in particular. The fact that you know all the lore and the background and the characters and what they did in a video like a year ago, like you can pull that stuff out. That is so fun for me. I love seeing that. But it's particularly helpful, those comments, for planning these Knock Knock Eye episodes. And so I really love going through those YouTube comments. And because all these episodes are on YouTube, the video, if you want to watch me, you can see how skinny I am. And let's see. So some really good ones on the eye worms. I was really looking forward to seeing what these comments were. I'll just read like a couple. Like some people were just like were super pumped. Like, yes, I clicked immediately. I was so excited to see an episode on eye worms. And if you haven't listened to it, please go and listen to it. I go over some of the most horrifying eye worms: Loa Loa, We got various nematodes and roundworms and things crawling in the retina and in the brain and along the optic nerve, all these places, all these things. So the one comment here at Nikki White 476. I saw the video title and said, "Oh Jesus, why do you do this to me, Dr. G?" And then I realized that someone had suggested it. Why? My eyes are itchy now and I haven't even watched it yet. I physically repelled from the screen when you talked about Loa Loa. 6 to 8 inches long, these worms. I'm never going anywhere you can get that. I want to vomit. I am so disgusted and disturbed by that thought. Thank you for watching and listening to that episode. I was also feeling a little grossed out going through all those different worms. Eye worms. Why are you like this? This is the most horrifying video title ever. Of course, I immediately clicked on it. Someone was very disappointed that I didn't have any eye worms to actually show you, because I did. In hindsight, like, why do I, like, I shouldn't really tell you, like, I don't have eye worms to show you today. Why would I? Be a very strange thing to hold on to. I feel like it's like something like an infectious disease specialist would do. I can't get the vision out of my head of Jonathan waving tiny flags from the sidelines, cheering on Dr. Glockenflecken while he plays Missile Command on a patient's eyeball. That was in response to basically to treat one of these worms, you shoot it with a laser. So I do enjoy that visual. So anyway, thank you all for the comments on the eyeworm episode. Go and check it out. It was a lot of fun to do. I've really enjoyed seeing the response there. Yeah. So and then going back to just, my thoughts about internet comments, because I get this question a lot. Like, do you read comments? Is it good for you? Like, how do you feel from because the common trope and thinking is that internet comments are useless and they're just going to make you mad and angry. And I mean, it depends on the content you're making, right? Like, when I make semi-controversial videos, which honestly I don't do a lot of, the most controversial things I do is when I, make fun of United Healthcare and stuff, and most people can get on board with that. But what I do, here's what I do. When I post content, I will read the comments, usually on TikTok. That's always the first place I post my videos. I'll post it to TikTok, and then it all pretty much immediately goes to YouTube. Or most of the time I'm recording these skits late at night, and so I'll post it at like midnight or 11 or somewhere like that on TikTok, and then I'll schedule it to post YouTube at like 6 a.m. And so when I post a TikTok, I'll read the comments for like maybe 20 minutes, if that, maybe even less. And then I just put it away for like at least 2 hours. I just go and do something different. And I just forget about it. And that was like a change I made that has really helped me, because you just get so sucked into the response, the dopamine hits of everybody liking your video and everything. And then you start to perseverate on the like one or two people that say something mean about you. Like, have you been getting sleep, Dr. Glockenflecken? You look horrible. I got a comment like that recently. You look tired. You got bags under your eyes. Yeah, I do. Did you know that I've had a cardiac arrest and cancer twice? I deserve to have bags. I have earned the bags under the wrinkles around my eyes. I have earned every spot on my face. It's just the way life is sometimes. And so anyway, those are the types of comments that you just like, why? It's not worth your time and energy to like think about those things. And so I started just like limiting myself and the amount of time I spend looking at comments. So anyway, that's my thoughts on comments. I try to get to as many as I can, but I can't hit the comments on all the platforms. I do see a lot of the ones on TikTok and YouTube. So if you want me to read your comments and your reaction, I'm most likely to do that on those platforms. And I appreciate all the humor, all the feedback. It really is a big part of what I do. All right. Should we get to our topic? I think that's enough. That's enough exposition here. So let's take a short break. We'll come back and we'll talk about thyroid eye disease. All right, here we go. Thyroid-related ophthalmopathy. Ophthalmopathy. That's a lot of consonants in that word. We love our consonants in ophthalmology. We like to throw little H's in there. We got a random L from time to time. It doesn't make any sense, but it is what it is. All right, so let's talk about this. And the reason I chose this topic is because it's fairly common. Thyroid disorders, I don't know how common those are just in general, but a lot of people have them. And thyroid eye disease is an interesting disease because it can cause severe problems for people, both functional in terms of your ability to see, but also cosmetic. And we have been looking for a way to treat thyroid eye disease effectively. We have things, and we'll talk about the different treatment modalities. But there's one that has come up recently within the past couple of years, which has changed the game for thyroid eye disease. And so we'll get to that in a second. So let's just talk in general, a few bullet points about this disease. So it's an autoimmune disease that exists on a spectrum of ocular manifestation. There's lots of different ways it can affect the eyes. All right, it's the most common cause, thyroid eye disease, the most common cause of proptosis in adults. So proptosis is when you have one or both eyes that just is sticking forward. We have a way to measure this. It's called a Hertel exophthalm. God, see. Sometimes I don't have the words exophthalmometer. Is that what it is? I just call it the Hertel. I've never used that second word. I swear to you, I'm a board certified ophthalmologist. Anyway, we use a Hertel. It's a little measuring device where you can measure how far forward the eye is in the socket. And so you see an eye that's proptotic, one eye moving forward. Sometimes it's both eyes. And this usually happens kind of gradually over time. The most common reason for that is thyroid eye disease. It's also the most common cause of acquired double vision. So double vision is a common symptom of thyroid eye disease in adults, I should say. Women are more commonly affected than men by about 8 to 10 times. So much more common in women. And here's the interesting thing. A lot of people will associate thyroid eye disease with Graves' disease. So it's like, oh, you definitely have, if you have thyroid eye disease, you have Graves' disease. They go hand in hand. Graves' disease, of course, is a form of hyperthyroidism. So high thyroid levels causes you to have thyroid eye disease. That's not totally true. Yes, patients are most commonly hyperthyroid. 90% of patients with thyroid eye disease are hyperthyroid, have high thyroid. But about 5 to 10% have normal thyroid. They don't have any blood levels of thyroid hormone that's outside the range of normal, yet they have thyroid eye disease. Kind of interesting. I've seen a patient like that. And then a very, very small percentage, about 1% of patients are actually hypothyroid. So it's not as clear cut as Graves' disease equals thyroid eye disease, but it's close, 90% association. So it is most likely to be that. And the chance of having Graves' disease and by association thyroid eye disease is about 7 times more likely in smokers. Just another reason not to smoke, everybody. Don't do that eyeball tip of the week, which I still don't have a sponsor for, is don't smoke. Don't smoke, please. Don't smoke, don't smoke, don't smoke. It causes all kinds of things. It also increases your risk of macular degeneration, thyroid eye disease, Graves' disease. It'll hasten cataract formation. dry eye. The list goes on, you guys. All right. Smoke billowing up into your eyes and just, come on. It's just not good. It's not good for you. Don't do that eyeball tip of the week. There's also an association with myasthenia gravis. 5% of patients with Graves' disease also have associated myasthenia gravis. It's kind of interesting. And quite often, the beginning stages of thyroid eye disease is asymptomatic. So patients may not know they have it at first, but then as the symptoms get a bit worse, you start finding these symptoms. So here are the symptoms. This is what you can see. So a patient comes in. We talked about the proptosis. All right, that's about 50 to 60% of patients will have some degree of proptosis. All right, you can see that. As soon as the patient walks in, I can tell. The eyes just have a certain appearance to them that screams out thyroid, thyroid, thyroid. And so they're more prominent, obviously, with the proptosis, but also there's eyelid retraction. So if you look at your eyelids in the mirror, you'll notice that the upper eyelid, it kind of crosses over the iris, the colored part of your eye. But when you have eyelid retraction in the setting of thyroid eye disease, that eyelid, think about it, that if the eyeball is being pushed forward, and we'll get to why it's being pushed forward in a second, then you can imagine that you'll be able to see more of the eye because that upper eyelid gets kind of pushed back up. And so what happens is you start to see the white of the eye above the pupil. All right, so instead of the eyelid, the upper eyelid, crossing over the colored part of the eye, the iris, instead, it's higher than that. And you're seeing the sclera, the white part of the eye, between the upper eyelid and the iris. All right, so that's eyelid retraction. It's so fun doing this because it forces me to try to really paint a picture for you, especially for those, for everybody, but for those who are listening, right? I can't show you the pictures. You can go and look at it. You can Google it later. But this is making me be very deliberate in how I'm describing these things. All right, so eyelid retraction, proptosis. The other ones are a little bit more subtle. One is called lag ophthalmos. So the eyes are being pushed forward. They're more prominent. The eyelids have a harder time covering the eye, the surface of the eye when you blink. So that's called an incomplete blink or lag ophthalmos. All right, the eyelids are not coming together all the way when you blink, and that leaves the surface of the eye exposed, which can cause some problems. And there's a variety of other symptoms and signs that can happen. You can get redness of the eye. You can get, especially over the extraocular muscles. So why is all of this happening? What pathologically is going on to cause these symptoms, the proptosis, the eyelid retraction, the lag ophthalmos? Well, what happens in thyroid eye disease is you get enlargement of the muscles around the eye, what we call the extraocular muscles. There are 6 extraocular muscles, right? 4 that make a lot of sense, 2 that are kind of weird. So you got the superior rectus, the inferior rectus, the lateral rectus, the medial rectus. They are exactly where you think they are. They're on the top, bottom, left, and right of the eye. All right, they pull the eye in different directions. So where are the other 2? Well, you have something called an inferior oblique, and you have a superior oblique. All right, these are 2 different ones. They're special. They participate in torsion, kind of twisting the eye one way or the other. Don't worry so much about those. All right, I don't. They make me crazy thinking about these oblique muscles. All right, don't tell a pediatric ophthalmologist I said that because they love those muscles. So anyway, what you get is enlargement of these muscles because the process of this disease, you get the muscles become infiltrated with cells, with immune cells, because this is an autoimmune disease. So you get lymphocytes, fibroblasts, monocytes. they get into the muscles and they start producing these mucopolysaccharides, these chemicals, which increase the size of the muscle. They just get enlarged. They get engorged with all these polysaccharides that increase the water content inside the muscle. So basically, the muscles get fat. They get engorged. They're just big, giant muscles. All right, they're swole. These muscles are swole. They are. If you worked them out and you had the ability to do that, then that's what would happen. They just get big and fat. Now, this is a problem. You don't want those muscles getting big and fat because there is very limited space where those muscles are. So if you recall the anatomy of the eye and orbit, the eye is sitting there within a bony orbit. All right, on all sides of the eye, there's a cone of bone. All right, think of it as a cave, and the eye sits at the mouth of the cave, and behind the eye, those bones taper back into like a cone. So the eye is like the ice cream cone, and the rest of the cone is bone. Well, those muscles are one of the many things that fill that space inside the orbit. So if they get big and fat, what's going to happen? Well, it's going to start taking up more of that space and eventually start to push the eye forward. And you get that proptosis. You get that eyelid retraction. And for a while, in mild to moderate cases of thyroid eye disease, this is mostly a cosmetic issue. And that's, people think a cosmetic is not that big of a deal, but this is a big deal because it can be really difficult for people to deal with that. Think about how important your eyes are, your face, your facial features. And so you have one eye that's proptotic, that's starting to push forward, and then comparing that to the other eye or both eyes, and it looks like you're staring at somebody. And so it can be very concerning which is a perfectly reasonable reaction to this, which is why it's such a challenging disease to have from the patient standpoint. So it's that cosmetic issues that are troublesome for patients. But then if you get fat enough muscles, what'll happen is those muscles will take up so much space in the eye that it'll start to put pressure on the optic nerve. And this is where you're starting to get into danger territory, because that optic nerve, that cable that runs from your eye to your brain, it's kind of important. We need that thing working. You put pressure on it, you squeeze it, it's not going to function as well. And so that's one of the main things. That's one of two big time things that we're thinking about with thyroid eye disease. We see a patient with thyroid eye disease, we are assessing that optic nerve every way we can. We are doing a pupil exam. We're doing color vision testing. We're doing what we call an OCT, which is an imaging study that we do in clinic of the optic nerve. We're physically looking at the optic nerve. We're doing everything we can to make sure that optic nerve is totally healthy and not being squeezed by those big old fat muscles. Big ol'. That's my Texas coming out. Big ol' muscles. So that's optic nerve compression is one thing, or optic neuropathy. Compressive optic neuropathy is one of the biggest problems. The other thing that we're concerned about is exposure of the cornea. I already mentioned a little bit of that, right? The lag ophthalmos, the eyelids, because the eye is being pushed forward so far that the eyelids can't close over the cornea. You need to be able to blink completely because that's what helps lubricate your cornea. All right, in another episode, we talked about dry eye. Now, you don't want the surface of the eye getting dry. It feels like needles poking into your eye, like a hot poker. All right, and it can cause the cornea itself to start sloughing off and thinning out, and severe damage, potentially even open globe perforations of the eye if you don't have lubrication of the cornea. So we see a patient who's got proptosis. We're also concerned about lubrication of the cornea, what we call exposure keratopathy. All right, we don't want that. And so we do a lot of talking in patients with proptosis for any reason, but especially for thyroid eye disease. We are talking about lubrication. We're prescribing ointments, frequent eye drops. Sometimes we'll even tape the eye closed. We'll have the patient tape the eye closed at night. Sometimes we'll even suture part of the eyelids together. It's called a tarsorrhaphy to prevent too much exposure of the cornea. So this can be a big problem. We're talking optic nerve compromise, cornea compromise, two very important parts of the eye. So what do we do about this? Treatment. So there is emergency treatment because thyroid eye disease can get so bad if it starts to put pressure on the optic nerve, we have to do something and we have to do it quickly. So oftentimes what we'll do, historically what we've done is start IV steroids to try to just decrease any kind of inflammation we can. You remember all those cells that are causing those muscles to get large and engorged, the lymphocytes, we're trying to quiet that down with some IV steroids. And then what we can do is called a decompression. So I mentioned the orbit, right? Those bony walls. Well, what you can do is actually, and this is pretty invasive, but you just bust through those walls with a surgery. You break the walls of the orbit. You can do 1 wall, 2 wall, 3 wall, sometimes 4 wall decompressions. And when you open up those, when you basically just make an opening in those bony walls of the orbit, it allows the muscles to relax and fill more space, and allows the eye to relax back into the orbit. Obviously, this is an enormous surgery. It's a very specialized surgery. Not everybody does this type of surgery. Usually it's an oculoplastic specialist that does this. I certainly don't do that surgery. But it's a vision and cornea saving measure that you mostly optic nerve saving measure to do that. And the recovery can be tough. I mean, patients get really swollen from that surgery, and but it can help. It can absolutely help. It can save vision, is what it can do. And then beyond orbital decompression, but even with that, often patients are still left with this proptosis, this cosmetic issue. And then sometimes they also have diplopia. They have double vision. And then you got to try to treat that, but you have to make sure that the eyes are stable, that they're not, that the thyroid eye disease is not getting worse or progressing. And there's different stages of thyroid eye disease. There's this escalation phase, and then a plateau phase, and then a convalescent phase. So you got to make sure the patient's in the right phase before you start mucking around with the with the eye muscles, doing strabismus surgery. And that's all way more than we need to talk about here. But what I do want to, the last thing I want to talk about with thyroid eye disease is this new medication. It's called teprotumumab. Teprotumumab. The brand name is Tepezza, but we're good students of medicine, so we're going to use the generic name, teprotumumab. I have no financial interest in this medication, in any medication, but certainly not this one. And this is a really revolutionary treatment. Okay, I've seen this work. So basically I'll just tell you what it is. That would probably be helpful. It's a monoclonal antibody that was initially developed to try to treat different types of tumors, but was later thought to be used in patients with Graves' disease who had proptosis. And the pictures, the before and after for these patients is remarkable. All right. It's an infusion, and I'm not totally sure how often they get this infusion, weekly or monthly. I'm not sure, but the results are fairly remarkable. Definitely, statistically, clinically significant. You can see the before and after pictures. Go check it out if you're interested. Teprotumumab or Tepezza, Tepezza. and it's it can be life-changing, this thing. The problem, if you could imagine, in the US is the cost. It is rather expensive, and you can imagine how difficult it is to get insurance to cover it. I've talked to some of my partners who, I have one partner that does this type of work and treats patients with this. It's a lot of phone calls. It's a lot of prior authorizations and some peer-to-peer reviews and, all the things that come with trying to get a very expensive brand new medication. But it's pretty cool. It really does a great job. So talk about just advances in certain diseases that we just didn't have great treatments for. I mean, the treatments worked, IV steroids worked, the decompressions, the thing, but nothing that's as effective and that's not as invasive, right? And so that's the benefit of doing this. So anyway, success story in the world of thyroid eye disease. You guys, that's all I know about thyroid eye disease. That's it. And I think I should wrap this up. We're at 35 minutes now. If you're listening to me on 2 times speed, or about 17 minutes in, that's a little fast. I listen to my podcasts on 1 1/4 speed. I listen to a lot of sports podcasts. It's my chance to turn off my medicine brain, because I for some reason keep doing projects, adding things that are medicine related instead of non-medicine related. You should all have a non-medical thing. If you're in medicine, if you're in healthcare, do something like bird watching. I don't know, something. Have a hobby that's not medicine related. I honestly say ultimate frisbee is probably my only hobby that's not medicine related. Anyway, what was I saying? Hobbies, things. That was it. That's it. That's our episode. I should just wrap this up instead of just drawing this out. Oh, I was talking about the speed at which you're listening to me talk right now. Anyway, thank you for listening. I'm your host, Will Flannery, also known as Dr. Glockenflecken. A special thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Brook. Editor and engineers, Jason Portiz. Our music is by Omer Benzvi. As always, reach out, leave your comments. I want to see those comments on YouTube. I want to hear your feedback. You can email knockknockhi@human-content.com, knockknockhi@human-content.com. Also check out our website, by the way. We have a tour. You guys, we're going on tour. My wife and I, Kristen, our Wife and Death tour. We've gotten rave reviews for it so far. We've done a few shows, sold out shows, mostly in California. And we're so excited to take it to other parts of the country. So go to our website, glockenflecken.com/live, and look for, see if we're coming anywhere close to you. Now, I do still practice ophthalmology, so I cannot go everywhere. I wish I could. We don't have that kind of time. My partners would not be happy with me if I just took a year-long sabbatical and did a 50-city tour, although that sounds so much fun. But we're trying to hit different parts of the country. So check it out, 10, 12 cities, something like that. And I hope to see you out there. All right, that's it for Knock Knock Eye for today. Thanks for joining me. Knock Knock Eye and Knock Knock Eye is a human content production.
Knock knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.